Yes, good afternoon, everybody. Thank you all for joining in our today's PEM lecture series. I would like to welcome you all that have joined in and thank you for all those that have been following our pediatric emergency medicine lecture series. And we hope you have been learning. And today we're going to be having another talk, which is going to be talking about identifying inflicted injuries in children, the practical approaches and next steps. And we're going to have our two presenters, Dr. Catherine Gupta, who is an attending physician at Children's Hospital of Philadelphia, and Dr. Juma Mbugi, who is a pediatric emergency medicine fellow at MUHAS. So just to remind you, for those that have joined in for the first time, this is a CPD accredited activity where at the end of this session, I will help you claim your 3 CPD points. The only thing that you need to do, just make sure that you write your name and your MCT number on the chat. And I would like to inform you that the MCT CPD claiming part is now working. So we are working to make sure that everybody gets his or her CPD for those that have joined in the previous PEM lecture series and we didn't give the CPDs out. But right now we are working on it so that everybody gets their CPD. These lecture series are also recorded for those that will not be able to join in this time, but also they want to review it next time. I'll share our YouTube channel where we always have this recorded lecture series that you can always go and check. So I would now like to welcome the presenters to take us through today's talk. Dr. Mbugi and Dr. Gupta, you are welcome.
Thank you, Dr. Humphrey, for the introduction. I am Juma Mbugi, the Pediatric Emergency Medicine Fellow at MUHAS. Together with me, I have Dr. Catherine Gupta, who is an attending physician at the Children's Hospital of Philadelphia. Our talk today will be about the identification of inflicted injuries in children, the practical approaches, and the next steps. So please welcome. And we have the objectives for our talk. We expect that by the end of our talk, every participant will be able to define the non-accidental injury and probably distinguish from accidental injuries. And again, maybe describe the risks and the red flag features, both on history and physical examinations. And at the end of our talk, we expect participants to have knowledge on the legal and ethical responsibilities, appropriate documentation, and the major goal is to prioritize child safety. This talk will have a number of abbreviations, long forms of some definition. What is kind of a physical abuse, which accounts about 16% of all substantiated child maltreatment cases. So before we proceed, I'm going to display my one case scenario and try to figure out how would you approach in this case. And then by the end of our talk, probably each and every one of you will be able now to approach such case. So our case is a 6-month-old female infant is brought to the outpatient clinic by her aunt at 2 p.m. The complaint was right leg swelling for 3 days. So the question is, how would you approach this case? So you're not supposed to answer right now. We want you to go into details after the end of the talk. So let's see the burden of child abuse in general in Tanzania. So there was a study that was done in 2009 about child abuse. The title was The Violence Against Children in Tanzania, and the findings were documented by a national survey in 2009. The study was done by UNICEF in collaboration with MUHAS and other partners. So what did they find? Um, they found that around 73%, which is nearly 3 in all 4 children, experienced physical violence before the age of 18. So physical violence in child maltreatment accounts for about 73%. So this was a questionnaire study. So it might have some drawbacks, but yet it reflects some of the problems in our society. And sexual violence, like girls, around 27.9%, which is 3 out of 10 experienced sexual violence, and boys, 13.4%, which is over 1 in 7 experienced sexual violence, and emotional violence as displayed in the figure. But our topic today is based mainly on the physical violence. Sexual and emotional violence is another topic which we are not covering today. So we are covering only the physical violence, specifically on the non-accidental injuries. So let's see the risks. What are the risks that the child can have or a caretaker are likely to cause inflicted injuries to the children? So we have the risk landscapes, which covers a child factor risks and a caregiver factor risks. So intrinsic factor, this is a child factor. What are the characteristics that a child can have that can predispose the child to having inflicted injuries from a caretaker? So these are epidemiological relationships. So it has been found that presence of chronic medical conditions is one of the risk factors, including another one, including prematurity birth, uh, age less than 1 year, and this actually accounts for high risk of mortality. And extrinsic factors, this is a caregiver factors, the perpetrator factors, history of mental illness, young parental age, low level of education, drug or alcohol abuse, and some domestic violence in the home. Those are some of the risk factors that can predispose a child to having the non-accidental injuries. However, these risk factors exist, we understand that, but non-accidental injuries crosses all socioeconomic and demographic boundaries. So do not be carried away by these risk factors. It can cross all the socioeconomic and demographic boundaries without predilection. So I would like to welcome Dr. Catherine to proceed with the red flags. What are the red flags in the non-accidental injuries? Please welcome Dr. Catherine.
Um, yeah, so I think the challenge before you as you are providing medical care to kids is the fact that kids injure themselves by accident all the time. So being able to pick out which children you need to be concerned have inflicted injuries. I'm also going to use the term non accidental trauma as well. And picking out these children can be really difficult. Some of the things that can help you in terms of the history are what we're calling these red flags. So, if you're getting an inconsistent story between the caregiver and the child, or it doesn't make sense between the injury mechanism and the developmental age of the child, that should be a red flag for you. Um, here's an example of what I mean by the injury mechanism and developmental age. So let's say you're seeing um, a 3 week old and they have broken their leg. And the story from the caretaker is that the child crawled off the edge of the bed and then fell. So 3 week old children can't crawl. So that does not make any sense. There's no way that that injury mechanism can happen. Other red flags are if there's been a delay in seeking medical care without a good reason. So there are many things that can delay seeking medical care. You couldn't find transportation, or you didn't have the funds. But in general, if a child has had a serious injury, you should get a sense from the caretaker that they have really made all of their best efforts to get that child to medical care quickly. And when there's been a delay of, several days or sometimes even longer, that can raise some red flags. Children that present to multiple different hospitals, oftentimes with like different episodes of injury, can be a red flag. Sometimes the caregiver is trying to avoid being repeatedly seen in the same facility for different injuries on that child, and so sometimes they are seeing like different facilities, so that sort of no one can catch on that the child is injured so often. And then finally, if the history of the story doesn't fit the injury type or severity. So another example here would be um, a child who has a relatively minor injury, like a toddler who tripped over their own foot and fell to the ground in a fairly low velocity fall, comes in with, a femur fracture and a forearm fracture and a skull bleed. Like that's very unusual. It's just not the right mechanism for those types of injuries. Next slide. And then there are also some red flags that you can pay attention to in terms of your physical exam. And these pretty much all relate to bruising. So it's really important in a child who has been injured, and you should be doing a full skin exam on them, particularly the younger the child is, because those kids, babies, toddlers, are not able to tell you their side of the story. So you're looking for suspicious bruising. And sometimes it's the location of the bruise that can be suspicious. So there are places on the body that don't usually get bruised. These include the ears, the neck, the torso, the buttocks, the genitalia. These are parts of the body that are generally pretty well protected and don't get bumped and banged around in the course of normal childhood. The other thing that's concerning is if the bruises are actually what are called patterned. So sometimes they're actually shaped like the object that made them. You can see actual handprints sometimes, or belt loops, bite marks, burns. That's always suspicious. The timing of the bruising can be suspicious. Now, active young children often have lots of different healing bruises in certain parts of their bodies, like their shins and their arms. But if you're seeing a lot of bruises and they're all in different stages of healing, which tells you that there have been repeated injuries, that can be concerning. And again, the context here really matters. If there's not a good explanation for why a child should be bruised, then that is a red flag. Bruises in non ambulatory infants should always have you put your sensors up. There's a saying that if you don't cruise, meaning like pull yourself along, you should not bruise. So those non-ambulatory infants, they need to have a really good explanation for why they are bruised. Next slide, please. So there's a physician who works currently out of a children's hospital in the United States. Her name is Mary Clyde Pierce, and she has really devoted her career to studies that help inform us when we should be worried about bruising. And she and her team came up with this clinical decision rule that's freely available on the internet, and anybody around the world should be able to get to it. And the bruising rule is called the 10-4 faces P rule. Most people will just call it 10-4 faces. And this helps remind you when bruising should raise a red flag. So the 10 part of this rule stands for TEN, torso, ears, and neck. These are unusual places to bruise, and you should think twice about them. The faces also refers to other areas for bruising. So the frenulum, so you should be looking inside of the mouth of any infant or young child that you're concerned about. And you should be looking for things like a torn or a bruised frenulum. This is difficult to get in young children by any type of accidental mechanism, and is often due to something being forced into that child's mouth. So sometimes a bottle or a pacifier has been forced into the child's mouth so that they won't cry or make a lot of noise. So the F is frenulum. A is for the angle of the jaw. This is like a really strange place to be bruised unless you've been sort of like hit or slapped or grabbed across the face. The fleshy part of the cheeks is for C. Again, really unusual to bruise this area of your body. The E is for the eyelids. And the S is actually referring to subconjunctival hemorrhages. So these are like bleeding within the white parts of the eyes that can be found in children that have been aggressively shaken. The 4 part of this rule refers to ages. So infants that are 4 months of age and younger really shouldn't have any bruises anywhere on their body. They don't move on their own. I mean, maybe they roll, but they really like if you put them down someplace, they're going to stay right where you put them. So if they have bruises, it's very unlikely that they did it to themselves. There's also a concern that for children less than 4 years of age, you should have a higher suspicion for bruising in any of these other areas. And then the P part is again what we had mentioned in terms of patterned bruising. Any
Hello, everyone.
Sorry about that, guys. Can you hear me now?
Oh, yeah, sure.
Sorry.
We can start
Classic.
over
My
at the patterns.
Okay. Yeah. My internet connection's a little unstable, but hopefully it'll be better now. So any patterned bruise, a bruise that takes the shape of an object almost never got there accidentally. So that should really raise your concern for a suspicious bruising pattern. Next slide. Great. And this is in case anyone is actually interested in the literature. This was the original paper that the 10-4 faces P came out of, again, published by Mary Clyde Pierce and her group. Next slide. These are some of the classic examples of what you're looking for. So you can see some bruising on the torso in this baby. weird place to bruise. You can see a subconjunctival hemorrhage in the white part of that child's eye. Right.
Yeah, you lost again. Okay, so the 10 4 versus P bruising rule, we can see some of the bruisings on the torso, subconjunctiva, ears, and the frenulum. And apart from that, we have radiographic red flags, which involves skeletal injuries. Mostly infants will present with rib fractures, especially posterior ribs. And whenever you find posterior rib fractures, this is highly specific for the non-accidental injury in children less than 2 years. So the other fracture skeletal injuries is metaphyseal corner fractures, which presents as a bucket handle fracture, which is also a classic for shaking. Whenever you see that, means that there was some violent shaking or twisting of the child. So think about non-accidental injuries. Skull fractures in infants without any apparent reason or mechanism. Think about non-accidental injuries. And then we have red flags in physical examination and the radiographic as well, especially in the abusive head trauma. So how will the infant present, or a child will present with a triad of subdural hemorrhages, as you can see on the images here, retinal hemorrhages, and encephalopathy. How does that come behind? Because all these two things, the eyes, especially the retina and the brain, are interconnected with the meninges, the brain coverings that covers the brain also covers the retina and the nerves supplying the retina. So you can have retinal hemorrhage, encephalopathy, and subdural hematoma. So what are the other concerning findings? Usually, as we have seen before, the torn frenulum, which means there was a forceful entrance of something on the mouth, dental trauma in non-ambulatory child, burns. Usually you can find cigarette burns, immersion burns, as you can see here on the picture, with a clear demarcation, can present with stocking or glove pattern. Abdominal injuries, unexplained intra-abdominal injury in any infant usually comes with high mortality. And you need to document clearly and use a body map to record size, shape, location, and color of all the injuries. So you can have a body map. If you can draw, it's good to draw and locate the size and shape of the injuries. You can also take photographs with scale, but with a consent, according to your local police. And record exact quotes from the child and caregiver verbatim. That means you do not change anything they're saying, you record as they say. And then you can have to notice the child's behavior and interaction with the caregiver. Some kids may be uncomfortable interacting with the caregiver if the caregiver was the perpetrator. So what are the key differentials to exclude? So we have things called the mimics. There are things that mimic non-accidental injuries. So yes, we understand we need to be highly suspicious for non-accidental injuries, but yet there are things that can mimic the non-accidental injuries. So what are those things? Let's see. So long as we're talking about non-accidental injuries, so we can have accidental injuries. In accidental injuries, usually mechanism match the child's developmental age. And the history is consistent with the child's severity of injury type and severity. And usually a child may present with just a single injury, isolated injury. But what are the key points? The key points is accidents do occur, but mechanism must fit child's motor ability and the environment. For you to say this is accidental, there should be a matching of history, matching of your physical examination, and actually the child's developmental milestone should match the type of and severity of the injury. So the other mimic is metabolic bone disease like osteogenesis imperfecta, rickets, scurvy, and usually these are supported by the lab clues. Other mimics is a bleeding disorder like hemophilia, of which you'll have deep muscle hematomas, joint hemarthrosis, prolonged bleeding after some minor procedures or trivial injuries. ITP, immune thrombocytopenic papilla, can also present with bruises, which can be confused with non-accidental bruising. So there are other mimics that from medical causes like benign skin conditions like Mongolian spots, hemangiomas, port wine stain. These are the things you can be confused with bruising from non-accidental injuries. Clavicle fracture, cephalhematoma, brachial plexus injury, infectious causes like osteomyelitis, neoplasms like leukemia, neuroblastoma, and can present with bone pain and pathological fracture that can be also confused with non-accidental injuries. So what are we supposed to do? Because we need to also clear the confusions and everything. What are the investigations to be done? First, skeletal survey. We need to do a skeletal survey. So which patient do we do skeletal survey? So usually it's recommended that all children less than 2 years with suspected non-accidental injury and selected children between 2 to 5 years. And what are we supposed to be doing? So you do a full series, including the skull, spine, ribs, pelvis, all long bones, hands and feet. And normally within 24 hours of your concern, you have to be doing this. So whenever you get a patient with suspected non-accidental injury, do not delay doing skeletal survey within 24 hours. And then you might need to repeat the skeletal survey within 10 to 14 days because you might detect some old healing fractures that was not detected initially. So why do you need to do skeletal survey? Because you can detect occult fractures and fractures at different healing stages. And the need to repeat is because you might miss a fracture, but a minor fracture that is missed by radiographic findings can be seen when it heals. So you can later come to see them. Again, we have the neuroabusive head trauma, like CT head. This is the first line in abusive head trauma. Why? Because it can rapidly be done and it detects acute subdural hemorrhage and skull fractures. And we saw the triad of abusive head trauma, the subdural hemorrhage, retinal hemorrhage, and encephalopathy. So we need to do CT to exclude those things. And you can do also the MRI if CT becomes normal or you have clinical suspicion of other things. So who is to be doing abusive head trauma neuroimaging? Any child less than 2 years with unexplained neurological signs or seizure or significant bruising. Okay, so these investigations should be guided by clinical presentation and the local safeguarding protocols. So you need to be doing skeletal survey, neuroimaging, and interpret and record and interpret the results of your findings, and must be written in your documentation with clear context or with a history and examination. So you might need to also coordinate or collaborate with the pediatric radiologist for skeletal survey interpretation. You might not need to make interpretation on your own. You need to also have a pediatric radiologist to interpret these images for you, because later might be used as a legal evidence. And ophthalmology assessment, we saw that kids may present, especially with abusive head trauma, may present also with retinal hemorrhages. So we need an ophthalmology assessment, like to do the dilated retinal examination by ophthalmologist within the set time, 24 to 48 hours. But again, the absence of retinal hemorrhages does not exclude abusive head trauma. So if you don't find retinal hemorrhage, that does not exclude abusive head trauma. So you should go ahead doing some other things. And the lab investigations. So you do investigation because you need to exclude also other mimics, like bleeding disorder, metabolic bone disease, and other causes like liver function test, bone profile, coagulation screening. And the aim is to exclude NAI or to differentiate NAI from accidental. Dr. Catherine, if you are back, please tell me.
I think I'm back. I'm probably jinxing myself here, but I can start picking it up, and then if I cut out again, you can take back
go ahead
over.
with additional investigations.
Yeah, I want to make one comment on the skeletal survey. I see this happen a lot at other hospitals that send children to the hospital I primarily work at in the US. A skeletal survey is not just like a whole body x-ray where you've put the baby on the x-ray plate and they're like, like their whole body in just one view. Like you really do need to capture, when it says full series, it's as though you were getting like an x-ray of the hand, you would normally get multiple views of it, and an x-ray of the long bones, you would get multiple views. So it's many, many views. Like at my institution, I think this ends up being about 22 different x-rays in a skeletal survey. So it's not just a baby gram or like a baby on a plate. Yeah. All right. And then, right. So you had just gone over some of the mimics and some of the ways that we do lab testing to rule out the mimics, because of course there's no lab test that will rule in non-accidental injury. And here we go. Yeah. And so these additional investigations are they're starting to become tailored to what you think is going on with the child. Certainly not every child needs these. So if you're very concerned about the abdomen in a child and think that there's intra-abdominal injury, then getting imaging of their abdomen is best. And this can be done either through ultrasound imaging, like a FAST study to look for free fluid, or actually oftentimes just going right to a CT scan, which will give you a better view of all of the organs. A FAST is unfortunately not always very accurate in pediatrics and can sometimes miss significant intra-abdominal injury. If you're thinking about some of the more unusual, like bone diseases, especially osteogenesis imperfecta, some of these actually require genetic testing. So, this is clearly something that you will not have in the moment as you care for that child, but may ultimately be required as part of the workup. And then if you have concern for any type of ingestion or poisoning, so, a young child presents like sort of unresponsive and you have no idea, or with seizures or things of that nature, sending some toxicology testing on them, if able, can be helpful, because a child who has sort of like, illicit or illegal drugs or substances in their system, that raises its own line of concerns regarding like child abuse or neglect. So, next slide. Um, and then, I'll speak a little bit on this generally, but then I am actually going to punt it back to Juma, because some of this really is context dependent. So where you are working is going to affect who you pull into your team and who you're speaking to next. But in general, you should think about your care for these children as being a collaborative approach. So not only are you involving potentially multiple specialists, we've already discussed having orthopedics perhaps involved, ophthalmology, you may need neurosurgery, and then other types of surgical specialists. But if you're concerned for non-accidental injury, you also probably want to involve like your social welfare officer, depending on your work, where you work, maybe case management. There might be legal implications as well. So this is really where you're going to pull in like your full team. Juma, I don't know if you have more to add from sort of the specific Tanzania perspective on what to think about with like ED management and reporting.
Yeah, I was going to also ask that, because we happen maybe not to have a mandatory reporting system uh, of child physical abuse in Tanzania. I don't know if we have that protocol. I'll actually want to know if we have a mandatory reporting system for us as clinicians. If we suspect a child is having non-accidental injury, are we required by law to make a report? So you can write on the chat box if we do have such guidelines and laws. But again, in our setting, we normally report to social worker. Any suspected child abuse, we report to the social worker, who will secondarily advance to ask or to take more history to the caregiver, to the victim, and they might also need to report to the head of department before they report to the police if the need arises too. So can I go ahead, Dr. Catherine?
Yes, yeah, you can go ahead. And I'm not seeing any answers in the chat yet about people's knowledge of Tanzania specific reporting protocols.
Okay. So it's upon us clinicians to report such incidences, because if we don't, somebody's life will be lost. And why do we report? It's not just to do like a clinical data documentation, but the goal of reporting is to initiate protective social services of the child. Our main goal of the talk is child protection, and the priority should always be the child safety. So we normally report to social welfare officers who in advance, they go to report to police, the nearby station. And the documentation, we have talked about documentation, and the documentation should be meticulous, and the charting should be quite objective. And because this record is not just as a data, but later may be used as a legal evidence. So if you don't document well, it's either the perpetrator will walk away with it, or the child's life will be at stake. So make sure you document well, thoroughly, each and every stage of your history taking, physical exam, and investigations as well. So safety and the disposition plan. So usually evaluation of siblings and contact children should be done. If you get a child right now, you need to at least go further, asking if the destination is having another child. So you have to also evaluate the siblings of that victim and their contact children. So children in the same care usually are at high risk as well. If there are like 4 children in the house and one is being maltreated with physical abuse, so the likelihood of others to be treated the same is also high. And it's recommended that we do a full physical examination of these siblings, especially less than 6 months. You also go ahead doing the skeletal survey and the CT head. So it doesn't matter whether they are symptomatic or asymptomatic. You do the skeletal survey and the CT head, no matter if they are asymptomatic. And age 6 to 24 months, you only do the skeletal survey. So what are the admission criteria? So children presenting with multi-system injuries or they are hemodynamically unstable, they need to be admitted. And children presenting with NAI and they need complex evaluation and continued care like IV medications, maybe respiratory support, oxygen therapy, they will also have to be admitted. And you can also need to admit the patient of which the safe discharge cannot be ensured. So some patients may come with non-accidental injuries which are not life-threatening, but yet you need to admit them because you are unsure of the destination safety. And the key discharge criteria here, medical stability, we have seen the hemodynamic status, safety assessment. So you need to have a multidisciplinary meeting to confirm the safety of the destination. Because before the child returns home, we need to make sure the home is safe. And establish a child protection strategy. Usually this is done by the social welfare and maybe the law enforcement as well. And do not discharge the patient if you have not completed all the required investigations, including skeletal surveys to identify occult fractures. So you finish your investigations first, and then you discharge your patient if other criteria are met. So usually before you discharge your patient, make sure you coordinate with clinical social worker for the disposition planning, because they are the ones that will initiate to establish the safety of the destination, or the child protection strategies will be initiated by the social worker. So the key point here is do not discharge until the destination is ensured to be safe. Follow-up requirements. We saw this, that you need to repeat skeletal survey within 10 to 14 days to identify occult fractures that were not detected initially. And then you might also need to notify the primary care provider for continuity of care and support. Dr. Catherine, do you want to talk about the AD pathway at the Philadelphia hospital?
Yeah, sure, I can. Um, this probably looks really tiny on your slide screen, but I wanted to call attention to it as an idea of a way, and there are many pathways like this. I'm most familiar with this one, but as a systematic way to think about these children and to keep track of what investigations are necessary for them. Because as you may note from this presentation, it can become a little bit overwhelming. Like, well, what age are they and what am I worried about and which studies am I doing? So the pathway that's thrown up here comes from the Children's Hospital of Philadelphia, which happens to be where I work. And my hospital has published a number of these pathways, which are all freely available. You can access them really from anywhere in the world with internet access. They are not password protected or anything like that. This particular one is for suspected physical abuse in children, and it sort of walks you through the green zone, i.e., what injuries are you not so worried about? The yellow zone, which is like, I'm not really sure, and how might I approach becoming more sure about if this is non-accidental? And then there's a red zone, which is clearly suspicious injuries or suspicious circumstances, and walking you through what to do with them. So this can be a good reference if you're caring for these children. Not all of these tests or images may be available to you in the place where you are working, but it at least gives you an idea what might be involved and can help you make decisions about whether the child you're seeing can stay where you're seeing them or if you need to transfer them to more of a referral site.
Yeah. Thank you. So can you go ahead, please, with the next slide?
Yeah. So I think this just really sums up what we've been talking about. The first step of identifying and diagnosing non-accidental injury is like you have to recognize that it's there. And if you're not thinking about it somewhere in the back of your mind, you will miss it because this can be subtle, and this can also be life-threatening at the same time. So you have to recognize it first. And then once you've recognized it, you need to be able to be performing the appropriate investigations, which include imaging and laboratory tests as well. You need to be able to work in a team with all of your other collaborators. These are other physicians, and then also ideally nursing, social work, perhaps law enforcement as well. And then the reason we do this is because the big goal is to protect that child. So you are that child's advocate. And these can be uncomfortable encounters. These can involve uncomfortable conversations with parents who feel as though they are being accused of something against their child. But at the end of the day, your obligation is to protect that child and sometimes to protect that child's siblings from any further abuse in the home. So just keeping that in mind as you keep yourself centered and grounded. Here's a big thing that I really want to call out. It is okay to report abuse even if you are not 100% sure. And actually, I would go further to say you will probably never be 100% sure. So if you are waiting for 100% before you're calling your social worker, your law enforcement, it is too late. You're missing cases. Um, it's not your role really to decide what happened. It's your role to say this is suspicious and needs more investigation. And then it's law enforcement's role really to decide how they want to progress in an investigation. In the United States, where I work, there are explicit laws that protect me and protect anyone else who has made a report of suspected child abuse or neglect. And those laws say that even if I'm wrong, if I made the report in good faith, meaning I was truly concerned for good reason, then I cannot be subject to penalty. Like a parent can't then take me to court for saying that I made the wrong call. So I encourage you all to report even when you're not 100% sure. So getting back to the case. If we all remember from the very beginning, and maybe you're thinking about this case a little differently now after our talk. You're seeing a 6-month-old infant, and she's coming to your clinic, and the complaint is for right leg swelling for 3 days. I think there's a next slide here that
I think
gives a little more info.
Sure. They can write down on the chat box what they think should be the approach before maybe we see.
Yeah, sounds good. Just for an additional history, as you're thinking about what you want to do, the aunt who brings this child in has been caring for her because mother is away for work. The aunt says that the child fell off of the sofa 3 days ago while she was learning to stand. But then later she says, actually, this child doesn't yet pull to stand, which, by the way, would be typical. Like a 6-month-old usually is not pulling to stand. A 6-month-old usually can sit, sometimes unsupported, sometimes even still with support. The aunt says that the child has been feeding normally, has not cried excessively. There are no other medical issues. And the child pretty frequently goes between the aunt and the mother, who live in 2 different households. So also, if people want to report in the chat any like potential red flags that they might have seen as we got more into the history. On the examination of this child, they are alert, they're interactive, they're smiling, and there's no fever that's present. When you turn your attention to the leg, you notice that the right thigh is swollen. There's some tenderness to palpation of the distal femur. There's no open wounds. There's no true deformity. None of the other limbs appear to be swollen. You do see a small linear bruise on the anterior shin on the right, which is the same side that the thigh is swollen. And it looks fairly recent to you. There are no other bruises. And in terms of development, the child that you're seeing indeed can sit independently, but is not pulling up to stand. The vital signs that you can see shown up here are all normal for age. And then, so you order initially some investigations to look at the femur. That's where the injury is. And the x-ray you get shows a metaphyseal corner fracture at the distal femur. This is what's known sometimes as the bucket handle appearance. This is a unusual injury to get by accident, as you may remember from earlier in the discussion. And so it should trigger you to think about more of a workup here. So you obtain a full skeletal survey, and that shows a healing posterior rib fracture of the left 7th rib. Again, this is a very unusual accidental injury to obtain. And now you have 2 injuries on this child in 2 different stages of healing, which should raise many red flags for you. One of the things you could think about as well here would be, could there be like a metabolic bone disease that's predisposing this child to fracture? And so you go ahead and you order the blood work investigations that you need. And really they come back pretty normal. So you do not think that the child has a metabolic bone disease or rickets. You get a coagulation screen to make sure that any of the bruising that you're seeing is not just due to a predisposition to bruise, and that looks normal. So here's what I hope stands out to you from this case. So the mechanism here really doesn't fit the development, because this child isn't standing, isn't cruising, isn't walking. Also, a fall from a sofa, which could, by the way, happen still accidentally, this child could have been sitting on top of the sofa and then toppled over, is really an unlikely mechanism to cause a femur fracture in and of itself. This is a pretty low fall, unless your sofa looks different than my sofa and is much taller, but most sofas are low to the ground. So this is pretty a short fall. There was this delay of 3 days before seeking care, which, unless there's another really good explanation for it, is a long period of time before bringing a child who won't bear weight on their leg to care. The child's cared for by multiple adults in different households, and so this is just a risk factor for non-accidental injury. And then there's bruising on this non-ambulatory child. And so that can raise some red flags as well. So your working diagnosis here is most likely that this is a non-accidental injury and that this has been inflicted. Again, you don't need to be 100% sure. We rarely are in medicine. This is certainly more than enough for you to be concerned about it and start doing all of the things that you would do in that case. The metaphyseal corner fracture in particular is highly specific for non-accidental injury in this age group. There are very few accidental mechanisms that cause this. And then you have that additional rib fracture at another stage of healing, another very unusual accidental injury. So taken together, this is concerning. Your immediate management is going to be the same medical management you would give to any child. So you want to immobilize the leg. This child has a broken leg. And then you want to figure out how you're going to safely discharge this child. So you're probably going to end up admitting them. It seems unwise to discharge them to the aunt's care. You're also not entirely sure that the mom is a safe discharge plan. And so involving social services immediately is recommended. You want to make sure that your documentation is all very objective. You want to use direct quotes. You want to document exactly what you're seeing without hypothesis of what could have caused things. And then you want to work on your multidisciplinary collaboration. So here's a question that I'm hoping some people will be brave enough to answer in the chat a little bit, which is how would you approach the conversation with the aunt if she starts to become defensive and she insists that the injury was accidental? This can definitely happen. So if anyone has experience in this or ideas of how they would address it, I would love to see. I'll give a moment for people to write their thoughts in the chat.
Dr. Humphrey, I think you can now take over and coordinate the chat box messages.
Okay, thank you, Dr. Mbugi and Dr. Catherine. So I'd like to welcome any of the participants. You can either unmute and speak and just give us a response, or if not, you can just write it down in the chat and we'll gladly see and just speak it out. So you are welcome to say what your thoughts. There is no wrong or right answer. So just feel free and write what you think will be your approach. Okay, seems like no response there,
Maybe
so I think we
nobody's
just
had
go.
this, which would be lovely. I don't, Juma, have you ever needed to have this conversation with a family?
Okay, yes, there's one
Yeah.
response from a participant. Let me just read it out.
Ah,
Okay.
So I would ask her without showing any bias and judgment to describe the mechanism of injury for the thigh fracture, but also highlight the old rib fracture that were picked up on X-ray.
Yeah, it's a great point because now we're no
So
longer just talking about one injury, we're talking about two.
yes, I'm the one who wrote that comment. So basically, I've had an encounter with a mother. In my case, it was a sexual abuse, which is even worse. For her, she came in saying that whenever she would shower the child will start wincing when she will be around the gluteal region, around the anal region. So I was like, okay, would you like me to examine and the rest? But I made sure I wasn't doing it alone because it had already raised my red flags because a 6-year-old boy should not be having any pain during bath time with the mother. In fact, the child would tell the mother, don't touch. The dad had reported to the mother that the child these days does not want me to touch the anal region when I'm showering him. So for me, that was already red flags. When we started to examine the child with a colleague, so that I wasn't alone, I brought in a pediatrician and we examined the child and we saw the perianal excoriations with some bit of discharge and the rest. And I had already put swabs so that I'm able to collect samples just in case. After that, it was very shocking for the mother, so I had to be sympathetic, but at the same time also empathy because I'm a mother as well, and just talk to her and ask questions like, does the child go to school? What school does the child go to? Does the child enjoy his school? Is it a new school? And then through that, I was able to understand that he hasn't been enjoying school for the last 2 weeks. Yes, it's a new school. He was very excited about it in the beginning, but for the past 2 weeks, he hasn't been excited. A 6-year-old boy can talk. So I started talking to him and I was like, hey, tell me about your school. Do you love your teachers and the rest? And so it was more of like a child-led consultation because the child could explain himself well. And it was through that consultation that the child said it was a fellow student who would take him to the toilet during lunch breaks and tea breaks. And it was basically a daily thing happening to him for the last 2 weeks. But I also realized that the mother is coming from a polygamous household. So I felt like there was a bit of negligence on her side. She wasn't very close to the care of the child. Now, with that, I also suspected that she probably knows there's a perpetrator at home. And maybe the story about the older child was something that she fed her son to tell me. So when I tried to be a bit more, to try and tell her that, hey, this shouldn't be happening to this child. I empathize with you. Can we inform the authorities? After all, we already had evidence. We took a few pictures using her phone and I asked if she could share it with me just for record purposes. And then, yeah, unfortunately, that case didn't go so far. But most of the time, when I was talking to the mother, I did not want to subject her to guilt, which she's already feeling. But I just made sure that she was safe enough. She felt safe enough to share her experience. I saw her several weeks later, child had healed and everything. And the mother was very grateful and she said she's going through counseling. So, yeah. But it's challenging, especially with a toddler who can't speak, to try and talk to the aunt. But also, I would ask the aunt for this particular case to call the mother so that we can involve her in the consultation because the mother is the primary caregiver. Well, yeah, but it's very challenging with toddlers. But then also, I wanted to find out where is the man in the picture? Where is the father? Where is the father? So in most cases, men tend to be very protective of their children, and they would not want anything like that to ever happen. So yeah, that's it. Thank you.
Thank you so
Thank you,
much
Sila.
for speaking up and sharing your story. I think you touched on a lot of really great points here. Um, So many great points. I might forget to reflect back on all of them. Sort of going in reverse, understanding the household structure of the child is certainly very important. We gave you very little information about this particular, like 6-month-old's structure, but absolutely you would want to delve deeper and understand more who really does care for this child, who are the other adults in their life. You brought up in your example, after speaking with the child that you saw and that child's mother, you had concerns related to school. You know, school age children have a whole other host of adults who see them on a regular basis outside of their family, their teachers. And unfortunately, that is another opportunity for abuse that we see. Um, we're getting good insight also in the chat, where some people are talking about essentially getting backup, if you will. So that may include having another physician come with you. That may include having non-physician staff that are also your backup, like security guards, if you feel that things are escalating to the point of violence. And I would say that um, unfortunately, patients can get aggressive or violent for many reasons, and this can be one of them. You, as the doctor, should never put yourself in harm's way. If you think this is escalating to the point that your physical safety is at risk, then you should always step away and get a good safety plan to approach the scene, if you will. Um, I will say that one of the things that I have found helpful when I have these conversations is coming at it from the shared viewpoint that we are all worried about the child. I have not yet met parents who don't love their child on like a deeper level. And even parents who have unfortunately gone on to do things to their child that are regretful, they still feel a deep love for their child. So coming at it from a perspective of you're worried about your child, I'm worried about their child, and it's my job to think of all the different ways that this might have happened to your child and how to keep them safe can be helpful. I also remind myself that I am not in charge of figuring out who might have done this to the child, and that I don't need to assume that it's the caregiver who is there with the child right now. So, a child might come in with a parent and have concerns for abuse. And I don't know that it was that parent who did it. Maybe it was a neighbor. Maybe it was a relative. Maybe it was a teacher. And so to come at it also from saying, you know, I think we both want to help protect your child and try to figure out what happened here and where this may have happened. Many caregivers are very responsive to that. Sorry, that was a lot of talking. Juma, you can take over.
Oh yeah, thanks. I don't know if we have another one who wants to speak, but I wanted to emphasize on the law that mandates us as a clinician to report the child abuse. So Dr. Britt shared in the chat box the Tanzanian law of the Child Act. It was revised edition in 2019. So it talks about the mandatory reporting system for clinicians, social workers, and the community as well. So every one of you can go through it on your own time and check, see how it requires us to do. Because if you do not report a maltreatment, child maltreatment or exploitation, then you are likely to be part of it. Because why are you not reporting? Maybe you are part of the program, part of the maltreatment, and you may be taken by law as a perpetrator as well. So let's read. Maybe we are not doing it because we don't know the law, but not knowing the law is not an excuse. Let's go through the document and see how we can improve our practice. And the other thing is this talk gives us a knowledge on how to identify the non-accidental injuries and, the pathway to go through. And I think from now onward, we will not miss the non-accidental injury, because if we do, then the child's life will be at stake. Because if suppose you are discharging a child with non-accidental injuries, and then tomorrow you hear that that child you discharged was, was assaulted or maltreated to the extent that he lost his life. So it's not going to be a nice experience. So from today, I think every one of us will be keen to identify the non-threatening, the non-accidental injuries and the pathway to go through after you recognize. Humphrey?
Yes. Thank you. Thank you all for a very nice and well elaborated presentation, which talks of a very sensitive topic, which I think everybody should be aware of. And thank you for all those that have responded. We have more responses in the chat. And I would like to say thank you all for joining in our today's PEM lecture series, and we hope that you have learned something. Just as a reminder, the document or the law act is within the chat, and just click on the link and you'll have the document with you to go through. But as well, all our lecture series are recorded and you can always access them anytime. You can always share them with your colleagues anytime. And I've shared on the chat the YouTube channel where you're going to also find this recorded Zoom link if you missed or you want your colleagues to learn about it as well. This is also a CPD accredited activity where you get 3 CPD points, given that you don't have any debt with the MCT, because now the system is working. I will do our best to make sure that everybody gets in their CPD. Just make sure that you have written in your MCT number on the chat for us so that we can easily track it and claim the CPD points for you. Having said so, I can say thank you. We'll meet again next month and we'll always inform you upfront of when we're going to have our next PEM lecture series, as we have this PEM lecture series every month, just to make sure that we keep on learning about pediatric emergency wherever we are working. Having said so, I'd like to wish you all a good evening and a good morning to our colleagues in the US. Thank you very much.
Asante.
Asanteni.
Hello.
Asante sana.